We're in Amsterdam, where the world's leading cardiologists recently met for their annual European Congress. And they've made some pretty big announcements for people living with heart disease and actually diabetes as well. And this is big news because every year another 60 million people around the world develop heart disease and the various complications and impact that it can have on their lives. So in this video, we're going to pick out the 3 biggest scientific announcements from that Congress, which we feel are going to have an impact not only on clinicians, but people living with heart disease as well. I'm Amrit, I'm here with Patrick, and we're the Goggle Docs, and it's a pleasure to have you with us. So let's start with our first topic. And nowadays you can't get away from this phrase, the skinny jab, aka Wegovy, aka semaglutide. This originally was developed as a diabetes medication, now available in a higher dose for weight management. And in this scientific meeting, there was an announcement regarding the use of this molecule in people with heart failure. Tell us more, and why were they looking at that in the first place, Patrick?
Well, so specifically it was about heart failure with preserved ejection fraction, and this is not an uncommon complication of obesity, hypertension, type 2 diabetes. So a lot of our patients have this condition, and there are little therapeutic treatments really available for that. We've recently had evidence in terms of reducing hospitalization for heart failure by using SGLT2 inhibitors, but it was really here there was some data using, as you say, Wegovy, the 2.4 milligram dose in people who are overweight, average BMI was 60, in a randomized controlled trial looking at heart failure with preserved ejection fraction. 2 primary outcomes, so one was weight loss, and the other one was looking at their Kansas City cardiomyopathy questionnaire score, which really just is a measure of quality of life and mobility in those people. And the outcome of the study was in this, the average age was 69, 70. They improved weight, probably not a big surprise, but also improved quality of life in terms of that Kansas City cardiomyopathy questionnaire score. So it's really the first time we've seen treatments to improve the quality of life. And again, I suppose we're left with this question: is it weight loss? Is it the GLP-1 itself? As far as I'm concerned, I don't think it really matters. Because we've got something to work. What we really probably need is another experiment just to convince us it's definitely true, because that's just one study. But I don't know what your thoughts were.
So Patrick, I agree. For me, really, I guess the interesting thing is a bit about what is causing this improvement. It's symptoms. It's a symptom score, isn't it? So it's about KCCQ and how the patient feels. And we know that weight loss will contribute a lot to that. We know that weight loss is, people with obesity is from a large number of people who do have HFpEF. And weight loss is associated with a number of key improvements in a lot of those symptoms. On top of that, they did look at some mechanistic aspects in terms of NT-proBNP and high sensitivity CRP, and they showed that improved. But we know obesity and reduction in weight also does improve that. So for me, I think it's very much weight loss. The key thing is that weight loss and reversing the effects of obesity in people with a number of chronic conditions, including heart failure, especially HFpEF, is the way to go forward. And how you do that, be it through diet, lifestyle, weight management in terms of bariatric surgery, or GLP-1 and high-strength GLP-1 molecules, that's really what I kind of gleaned from this. And I was quite intrigued because I looked at it from a bariatric and a weight loss perspective. If it's just weight loss, do we have any data looking at bariatric surgery? Because that's the kind of closest or more improved than the GLP-1 therapies that we have. And there isn't really much data on heart failure outcomes with bariatric surgery. There's a bit about HFrEF and some improvements, but not really much on HFpEF. And I think that's the key thing. That's a key evidence gap, really, that we need to look at. And some of the trials that have been done in bariatric surgery need to look at this as an outcome, because I think it'd be really interesting to put this trial, STEP-HFpEF, in perspective when you look at weight loss as well. So for me, that's an interesting thing. And one little thing to mention, you mentioned BMI of 60, it's actually BMI of 36, wasn't it, or so?
Oh yeah, BMI of 30, age 69.
BMI over 30 was everything,
so,
the inclusion criteria, yes. Yeah. So for me, that's the thing. I think it's weight loss is important, and in this setting it was GLP-1. So for me, in a practical setting, I would look at it and say, well, actually, patients who have obesity and who have heart failure, okay, there's another incentive to use. But it wouldn't necessarily be, for me, I mean, even the breadth and the significance of that KCCQ score improvement, I need to know if it's just weight loss or if it's more, and I don't have enough based on this.
One question, just to wrap up this sort of area, and it's just coming back to you about weight loss in people who've got heart failure with preserved ejection fraction, perhaps a little bit older, concerns about muscle loss. Is this something that, we just need to keep at the back of our minds? We can't just be all guns blazing, I suppose.
It's an interesting area. It's a whole separate area, really, because if you're improving, weight reduction, it's muscle mass reduction, but also is it, skeletal muscle as well, and is that going to contribute to sarcopenia and frailty?
Yeah.
And to be honest, the evidence is limited in that. There's some data suggesting maybe it doesn't quite affect. Some of the newer molecules don't quite affect that side of things. But I think it is something important. Also bear in mind that heart failure itself contributes to frailty and worsening frailty. So if you can improve the heart failure, then can you improve that frailty status? And this is an interesting area. Again, with SGLT2 inhibitors, there's some area of interest in that and some data. But again, GLP-1s, that's the next stage. And there's some new molecules looking at preserving skeletal muscle as well. So stay tuned. There'll be a lot more we talk about this, but it's an interesting topic.
Okay, so let's move on to the second key message that we got from this scientific meeting of the world's top cardiologists here in Amsterdam, and that was really looking at lipid management. So we know that reducing lipids can have a positive effect on reducing the risk of cardiovascular events. We know in the UK with QOF, for example, this year we've got newer targets with tighter targets for LDL and non-HDL cholesterol. So we also know there's a challenge with using statins for some patients, whether they're resistant to it, intolerant to it, or whether using a statin is just not enough to reduce lipid levels. And we got some more information during this meeting regarding non-statin therapies. Can you give us a bit more information about this?
I don't mind picking up initially.
Yeah.
We got some. We're talking here about the CLEAR Outcomes study. So it was presented earlier on this year, actually at a different cardiology conference. But we've got further data, particularly in terms of primary prevention. They looked at the subset of CLEAR Outcomes. About a quarter of those patients, quarter to a third, hadn't had any ischemic event. So there was this primary prevention. It seemed to work, if you believe it, even better in primary prevention than secondary prevention. I think that's probably a spurious thing, but we've got now probably the best evidence in terms of a tablet for people who can't take statins. And as you say, on a practical basis, that's actually quite a large number of patients, particularly since we're going to be targeting those in terms of secondary prevention, we're looking at those tighter lipid guidance. We're not going to get there, I think, with ezetimibe on its own. So gives good reassurance that we've got other agents now that work, and there were some harms. I don't know if you want to go on to the harms. There was a doubling there was a 50% increase in terms of relative risk of gout, and there was also an increase in terms of gallstones as well. But I think it gives us those additional options, and in truth, it's part of standard therapy really now, certainly for my patients who can't take statins. So that's good confidence to think that I'm doing some good.
And just to remind you all, we're talking about bempedoic acid, which is a citrate lyase inhibitor, so works higher up in the pathway to statins. So this is where the CLEAR Outcomes trial was looking at bempedoic acid against placebo and showed the benefits that we saw. I think that gout events is quite an interesting one, actually, and it's something that probably does need to be highlighted and mentioned a few times. I think it's something that does need to be highlighted to the patients that we speak to, and that it can possibly be. And a lot of our patients with the metabolic syndrome picture, there will be some higher risks in that group as well. So I think it is important, and it's something to mention because it's shown in those trials in a number of those situations. So yes, I would say that. But apart from that, it's a valuable option certainly. And I work in secondary care, but use a lot of it. But also do work a bit in primary care and using it more and more frequently. I would say there is more evidence, more reasons to use it in statin intolerant patients. What that means, I guess, is an interesting one.
Statin intolerance, what does that mean? Because is it that the patient just doesn't want to take it? Is it because of symptoms biochemically, or is it because of reading the Daily Mail? What's the reason?
All of those. Basically anybody who can't take a statin, I think, is in my mind. But this, as we say, with bempedoic acid now, we've probably got the best evidence outside of statins in that tablet. So better evidence than we have for ezetimibe, which people are probably more confident at using, but maybe we need to be more confident at using agents like bempedoic acid now.
Fine. Anything else from the lipid field that we just need to include in this second section of our video?
I guess there's a brief thing about LP-little-a, so lipoprotein A, which is I guess it's something that's not, it's used in practice, used by a lot of our lipidologists and our chemical pathologists, but perhaps not so much in primary care, and perhaps even as a secondary care, I don't use it really either. But generally it's coming, and there's a lot of things. It's looking at LPA, which is perhaps a subset of the whole LDL kind of bad cholesterol kind of molecules, and it's perhaps looking at contributes more to lifetime risk. So there was a kind of a guideline last year looking at LPA and how to utilize it in terms of risk stratification assessment of patients. And it's saying basically if your LPA scores are high, you've got high risk regardless of what your LDL is doing, so you treat them as high risk. What that means in terms of lipid lowering therapy, well, we've got a few trials coming in looking at molecules that particularly target LP-little-a. These are in phase 1 and phase 2, so perhaps not quite yet, but in a few years' time we will be having these specific targeting molecules. Apart from that, I guess we have some evidence with existing molecules as PCSK9s looking at that area. So it's kind of saying, well, perhaps not for primary care and maybe not secondary care as much as more the specialist care, but it's something that was talked a lot of in that conference, actually, something that's going to be coming.
Okay, great. So let's move on to our third and final key area from this scientific meeting. And it wouldn't be a scientific meeting if they didn't discuss guidelines. And there were a number of guidelines discussed, weren't there? But in particular, an area that interests all of us is diabetes. So there's an update to the European Society's guidance on cardiovascular disease in diabetes. We won't go through all of the details, but perhaps some key areas that stood out for you guys?
Well, I think one of the big changes was use of SGLT2 inhibitors using with people with a risk above 10% over 10 years. I mean, they came up with SCORED2 as a way to calculate that, which is obviously a bit different from what we're doing in the UK, but it's that similar ethos in a sense that if you've got a high cardiovascular risk, you use SGLT2 inhibitors, in this case, in preference to metformin, although in the UK, of course, we're suggesting dual therapy. But we're seeing this shift, I suppose, really, of using these treatments in terms of SGLT2 inhibitors, which were originally glucose-lowering agents, now into that sort of reducing that cardio-renal risk. Yeah. So right from the get-go, really, in terms of therapy. So yeah.
And it speaks to that question that keeps on coming about, isn't it, about metformin's role. And do we start with metformin and then have an early sequential addition of SGLT2 inhibitors? And it will continue with this debate, won't it? Amar, your thoughts?
Yeah, you remember back in 2019 when the ESC guidelines in cardiovascular diabetes came out, that's when they first mentioned pushing metformin slightly to the side and saying, let's look at these molecules with better evidence for cardiovascular risk reduction. SGLTs, GLP-1s. So it's not just SGLT2s. GLP-1s are also mentioned in this guideline as well, with evidence of cardiovascular risk reduction. And this just builds on that and is strengthened by kind of the evidence that we keep having about all these medications. And GLP-1s now are starting to kind of get more and more prominence in that. I think as a diabetologist, I'll never give up metformin, not from a cardiovascular point of view, but from the other multitude of effects we've seen that potentially it has, also the glycemic lowering. They do use it in glycemic lowering as well, but first and foremost is the cardiovascular risk reduction. And then if you want additional glycemic benefit, consider metformin. Obviously, that's from a cardiology perspective. Fair enough.
It was a cardiology meeting.
I can't argue with that. So, but from my point, I'll always go with that and say metformin. So I like the NICE guidelines where it's concurrent use. So metformin and look at when to use SGLT2 as well. That risk, and it's QRISK2 score, isn't it? Or it's just 3 now, isn't it? With the NICE guidelines, whereas it's SCORE2, which is slightly different. But again, it's cardiovascular risk and at 10% cutoff basically.
Fine. Was there anything else in the guidelines that stood out for you?
I guess again, it comes back to focusing on this obesity and weight management, and now it's not just in diabetes, type 2 diabetes, but also in cardiovascular disease management. So they focus and say, well, look at weight management, actively look at steps to reduce weight in individuals to reduce their risk of cardiovascular disease. GLP-1 therapy is mentioned. I'm not sure if higher strength is mentioned as such because we're still coming to that, but certainly GLP-1 is mentioned. And of course, they've also mentioned bariatric surgery. I think is very good, very nice for them to mention that, because that's again, if in terms of weight loss, that's still the best thing that we have at this moment in time for the right people and the right patients. So again, that's highlighted. One last thing also I want to mention, they also mention, is you said cardiorenal disease. So it's not just SGLT2s in that group, they also talk about finerenone, a non-steroidal MRA. So again, now we're seeing more and more of these molecules that the evidence base has shown a benefit coming into guidelines. I think this is something in the UK that will slowly also make its way, if not already, with the NICE updates.
Okay, brilliant. So really touching on a wide variety of different areas, aren't they? So although it's a cardiovascular disease in diabetes, we've got a bit of obesity that comes naturally into that, CKD as well. So developing, isn't it, and expanding, multimorbidity. There we go, there we go. Brilliant. So those are the three main areas that we've covered today. So first of all, we looked at the role of Wegovy, high-dose semaglutide, in heart failure with preserved ejection fraction. Then we looked at some of the newer, perhaps novel agents, if you want to call them, non-statin agents in lipid management. And then finally, we've given you an update of the cardiovascular disease and diabetes guidance from the European Society. Any top tips you want to leave our viewers with? Maybe just one or two things to take back into their clinics, or if you're someone living with these conditions, to discuss with your clinician.
I think that there's this increased focus on we've had a glucocentric approach to particularly type 2 diabetes, and then we've gone more to a cardio-renal approach. I think increasingly it's a weight-centric in terms of not just preventing complications and preventing disease progression, but now we can see not only in people with diabetes but outside in actually treating some of the symptoms of complications such as heart failure with preserved ejection fraction. And as you say, if we go to outside of a cardiology piece to that more broader multimorbidity piece, I think we can see the benefits across a spectrum of diseases increasingly, and I suppose that's a big change and a shift, paradigm shift, I suppose, in terms of how people approach managing these conditions.
I think you said it all there, Patrick. Can you top that with yours?
I can't top it because that's exactly what I would have taken home from it, to be honest. But I guess the other thing to say is about, again, it's about risk factor assessment, risk reduction, assessing that risk, identifying the people at risk, and using whether you use SCORE2, whether you use QRIS3. It's identifying that group, being aware that in such populations that we see diabetes, cardiovascular disease, obesity, we need to assess the cardiovascular risk, basically, and that's the key thing I'd say from the guidelines.
So there you have it, our top three takeaways from this cardiology scientific meeting here in Amsterdam. We hope that was beneficial to you and interesting. If you want to carry on the discussion, please do leave some comments underneath this video, and reach out to us across our social media platforms. We're also on Twitter as well. The guys are very active on our Twitter page, or X as it's now called. But for today, that's all. We're off to discover the rest of Amsterdam, but thank you for joining us, and hope to see you again soon. Take care.
Bye now.